I'm here and it's Facebook Live every Tuesday at 7 o'clock, and it's deleted me because I was late. So I had to re-put all the details in. So I don't know what that involved, that deleting thing, but I think I did a broadcast post and then gives you 10 minutes to comply. And then if you don't comply within 10 minutes, because I was at theatre and I thought, shall I come home? Shall I do it in the clinic? But last time I did it in the clinic, the internet connection was terrible. So this is me, Jonathan Staiano, live Q&A. Got some questions here tonight, and I am going to pull them up from my pre-designated area where I have them somewhere here. Here we are. Good evening, Jade. Nice to see you here. We have got a question here which says, I have lots of skin to sort out after ditching weight. I've not lost it. I don't want it back. What order would you work in? Which bits would you do first? And how many procedures can you do in one go? So the order that you do it in doesn't matter, really. In surgical terms, so I would go on what areas affect you most. Usually after weight loss, it's the tummy. The sort of value for money areas are tummy and breast. And so weight loss, it's usually a breast lift to tighten the skin of the breast, and a tummy tuck to remove the skin of the tummy. And sometimes if the breasts need to be bigger, then it's a breast augmentation. So it's some kind of combination of things. So it's usually breast and tummy, which you can do at the same time. Or, oh, here we go. The next part of the question, how many bits would you do in one go? So usually the tummy is the main problem, or the breast. Those are the sort of main areas. So I would just address the main areas first. Also the tummy and the breast are good because you hide the scars. The tummy tuck scar is hidden in your underwear. The breast scar is hidden in your bra. The other sorts of areas that people don't like when they've lost weight are things like their thighs and their arms. And those operations create more scarring, or at least not more scarring, more visible scarring. The arm gets a scar going down there. The leg often needs a big scar. If you lost a lot of weight, big scar down the medial part of your leg. So it's a bit more visible. Those scars are a bit more visible, and so less popular, I would say. So not, the main popular operations are tummy and breast. And but I would say it depends on the person. I mean, if arms really bother you, there's no point in having your tummy back done, because I've said so. Have whatever you want done first. So what order would you work in? So and how many procedures can you do in one go? So there's limitation surgically, and there's limitation from you as well. So from your point of view, it's a big op having more procedures in one go, but I can understand how people want it done because they just want to have one recovery and just get it over with. It's quite common to have a tummy and a breast procedure in one go. Depends on what you need to your tummy. So there's different levels of tummy tuck: mini tummy tuck, full tummy tuck, and then circumferential tummy tucks, or extended tummy tucks, which go all the way back, and they get increasingly bigger operations. So you can still have that with the breasts. One thing you've got to think about is positioning on the table. So like you say, how many operations can you have in one dose? Sometimes people don't like rolls of fat on their back. But if you're having sort of a tummy operation and a breast operation, and you don't want rolls on and you want the rolls on your back addressed, you have to think about positioning. So if you can access all the areas in one position, so if you're lying on your back, you can access the breast and the tummy relatively easily, then it makes the surgery a lot easier. If you have to rotate the patient, if you have to turn you on your front to operate on your back, that adds a significant extra level of complexity. And so I would probably say, look, you're better off having the front stuff done and then the back stuff done later, unless of course it's all in one circumferential or tummy tuck sort of thing. So that would limit the amount of procedures, and also the length of anesthetic. So it is common to combine procedures. You can combine a breast lift with an arm lift. You can combine a tummy tuck with a thigh lift. But I think it would be a little bit unsafe to do a sort of arm lift and a breast lift and a tummy tuck and a thigh lift sort of all in one go. So you'd probably want to stick with certain areas just because of length of time. You know, these operations take a few hours each. So I say, so, you know, 2-3 hours for each operation. So, you know, 4 to 6 hours for a tummy and a breast is sort of, you know, quite a long operation. But then if you want to do a tummy and a breast and an arm, I think that would be too much. So I would probably limit it to sort of 2 things. At the same time, you can do some liposuction to some areas, but I would limit it to sort of 2 main areas. So tummy, breast, arms, thighs, I guess, are the main areas that need addressing. And I would do sort of two is what I would recommend. Oh, here we go. Jade's in, straight in. Number 1, Jade. Is there a minimum BMI stroke weight for someone to have weight loss surgery, such as a gastric sleeve or bypass? Yes, Jade, I think there is. Jade, this isn't my field, so I would treat people after they've had their bypass, after they've had their weight loss, to do body contouring surgery, like the stuff we're talking about, the breast and the tummy and all that. But I wouldn't do the bariatric surgery. I wouldn't do the gastric sleeve or the bypass. That's a bariatric surgeon who's well, pretty much always is a general surgeon by training, who then specializes in bariatric surgery. But I think there is. Well, and I think it's different, obviously, in the NHS and in the private sector. And I think I'd be making these up. I think it's something like 40 in the NHS, but I think it's lower in the private sector, maybe sort of 35 or something. I don't know, Jade, but you're probably best off reading your local private hospital. They'll know. If you know they've got bariatric surgeons there, they'll know. But sorry, Jade, that's not really my thing. The bariatric surgery, the weight loss surgery. I fix people once they've had the weight loss, but I don't do the weight loss surgery. But thanks for your question. If I could thumb you up, I would. Thumb you up. That's all right. Give you a thumbs up, but I can't on this thing. So, because I've got this fancy system, so if you notice from the frame, I added that myself, the frame and the little picture. Where's the picture? No, is it there? There's the picture, yeah. And the little thing of the question there. Yep. No expense spared. I've had some comments about my beard being asymmetrical. You know who you are. Is it asymmetrical? Anyway, done my best. The importance of diet post tummy tuck. This was a question from last week, which I missed. Sorry, slightly off topic. Not sure what the topic was, but something. Well, sorry, something. Let's start that again. The importance of diet post tummy tuck. So, great question. Slightly off the topic. Something you might consider in the future for patients opting for abdominoplasty is advice diet-wise post-op. I researched a lot for myself, but I know others who have gone in clueless, so to speak. By this, I mean the importance of drinking lots of water, the use of Movicol sachets, light, high-fiber meals, arnica tablets, etc., all of which helped me immensely in a very quick recovery after a general anesthetic, stroke, stitches, etc. Yeah, good point. Do we yeah, perhaps we don't advise people enough about this sort of stuff. Sort of advise you when you're in hospital, but very good point. So abdominoplasty is one of those ops. After any operation, there's a risk of op being short for operation. There's a risk of constipation, and that's why I always say to people, be careful with the painkillers. And this is on all the post-op instruction sheets. If you have pain, obviously take painkillers, but don't take them regularly if you don't need them, particularly codeine-based painkillers like codeine phosphate, cocodamol, coproximol, things like that. Those are opiate painkillers, and they will constipate you. They can also make you feel dizzy. They can make you feel sick. But the constipation can be a real problem after any operation, but it's a particular problem after tummy tuck. Can you imagine being constipated and having to sort of strain and having had a tummy tuck? Disaster. So you've got to be really careful with that. So I like things like ibuprofen and paracetamol if that can control the pain. Certainly with a tummy tuck, I say crunch over more because constipation is an issue. So this Movicol thing and stool softeners and like things that will help you with your bowels is a very good thing after a tummy tuck to keep everything moving. Also getting up and about, light high fiber meals, like it. I'll steal that sentence or phrase. Arnica tablets. Now, arnica is a really interesting one. some people do talk to me about arnica and say, can I use arnica? And I say, yeah, you can use arnica, no problem at all. A lot of people say it's really good and really helps with the bruising. I don't particularly recommend it to people. I don't tell them to use it because bruising isn't much of an issue. Unless you're having if you're having liposuction, then bruising can be an issue, but it's not a huge issue for most ops like breast augmentations, tummy tucks. Sometimes you do get some bruising, and there's no harm in using an arnica, but it's not something I particularly recommend. I don't know if it's got any side effects, but I don't really recommend something unless it's going to benefit. But a lot of people anecdotally say that arnica is good and is a useful thing to have. So yeah, I mean, arnica, light high fiber meals, Movicol, or other sort of laxatives, if you like, to help you keep everything moving is a really good thing. Getting up and about and moving is a good thing. Keeping mobile is really important. And something else that so yeah, moving is also good to keep the blood circulating. What have you can also be a problem after a tummy tuck. So we got another question here. Why such a big range of prices for exchange of implants? I would like implants removed, re-put in an IMAX, Tipex. I think this must be predictive text. Say I am 559, size 12, but everything is going south. I have the band implants, Allergan, textured, December 2009. They were putting the need to come out at 300 in each breast. Meant I would like new implants in and a mastopexy, as both breasts are sagging due to my age, need some of the built-up fat taken out, skin cut back and redone. Think that is what mastopexy means. Right, okay. So I've put this question in because this patient has asked for a price for changing implants. And the problem is when we give people a price for changing implants, we say price for removing implants, okay, and not putting back. That's easy. Then we say price for changing implants, but also price for changing implants and price for changing implants and capsulectomy. So there's two prices: price for changing implants and price for changing implants and a capsulectomy. Now, we talked a couple of weeks ago about en bloc capsulectomy and removing implants. If you're just removing implants and not replacing them, capsulectomy is not so much of an issue. But if you're removing implants and replacing them, then you might need to do a capsulectomy, which increases the risks and increases the time of the surgery and makes it a much bigger operation when you do a capsulectomy, and it increases the price, more importantly. So the price for a capsulectomy is a lot more expensive than just exchange of implants. So if you've had the implants in just a few years and the implants are nice and soft, then there's no problems and you probably won't need a capsulectomy. You can just take the implants out, put new ones in again. You might need to do something to the capsule, but not remove the whole of the capsule. If you have got a problem with hard breasts and hardness around your breast, then you may need a capsulectomy where all that scar tissue needs to be removed, and that's a big deal. That's then a big op to remove all that scar tissue, put new implants back in. That's called a capsulectomy. So that's why there's two prices there. So with and without capsulectomy, it's a lot more expensive with capsulectomy. So implants have been put in for a long time. These ones have been in for 10 years, so there may well be a capsule around them. The other price thing is the mastopexy. So a mastopexy is a lift. So sometimes if you're removing the implants, particularly if you're not replacing them, or if you're downsizing them, or if over the years your breasts have sagged, then you might need a mastopexy to tighten the skin. So indeed, a mastopexy is the name given to tightening the skin. So then you've got prices for exchanging the implants and mastopexy, and then you've got now prices for exchanging the implants and capsulectomy and mastopexy. And then you've got different types of implants you can use. So you've got silicone implants, which are one price. You've got polyurethane foam implants, which are another price, which are more expensive. And then you've got B-light implants, which are more expensive again, the light silicone implants. So you've got three different prices of implants. So it is a bit of a minefield. So we tend to just say prices from this for exchange of implants. I think we give a price for exchange of implants and exchange of implants with capsulectomy, but you may need a mastopexy, and that'll be a different price. So that's why I wanted to explain why it looks like we're like, oh, when someone says, I want new implants, what's the price? And we might look a bit cagey by saying, oh, well, you know, it depends what you have done, you know, from this and what you have done. It probably really needs a consultation to see exactly whether you need a capsulectomy or not, and whether you need a mastopexy or not. And if you're going to have your implants changed, what sort of implants you want to have them changed to. So, yeah, I just wanted to clear that up. So Jade is back in. Sorry. Oh, God, dear, I tell you what, it's been all go today. It hasn't really been all go today, to be honest. But it's just a rush at the end. I'm annoyed I got here late. So the thing. Anyway, Jade. Sorry, I didn't even think. How are breast implants inserted? I've seen some under the nipple and some through the bottom of the breast. Is this a personal choice or where the implants are placed? Personal choice to a degree. To be honest with you, Jade, it's usually up to the surgeon, and there are different places the implants can be. There are different incisions you can make. Good question, by the way, Jade. Came straight back with a very good question. There's different places you can put the implants and places you can put them. So you have to make an incision somewhere. That's the first thing to say. You have to have a scar. And so the various places you can have the scar. First of all, inframammary fold. The fold where the bra sits, which I think what you're describing there is the bottom of the breast. That's the one that I use most often, to be honest. But that's number one. Number two, as you say, underneath the nipple, a U-shape, infraareolar, it's called, a U-shape incision where the areola is. Number three, armpit, transaxillary. And the other one that people talk about is the belly button. But the belly button is transumbilical breast augmentation tuber, but that's really just for saline implants because you put them in and blow them up when you're in there, which is we don't really use in this country. They use them in America. We don't really use them here. So the belly button, forget that one. So basically it's breast fold, infraareolar, and armpit are the three. And there are good things and bad things about all of them. There are people out there doing all of them, or you know, they're all being done. So it's not like one's best. So if someone says this is the best one, I'll be like, well, why does the guy down the road do the other one? You know, so there's good and bad about all of them. Now, in this country, and me personally, I prefer the mammary, which is in the fold of the bra. I prefer that one, and most surgeons, I think, in this country do that one. But I prefer that one because it gives good access to the breast. It's easy to control this bit here, the cleavage area. You can see it quite easily. You don't really touch the breast too much, whether you're putting the implant in front of or behind the muscle. You're not really cutting through any breast tissue. Sorry, itchy nose. So I like that one, and the scar fades really well. It is quite obvious to start off with. The reason people don't like it is because there is a scar on the breast. There's no question about it. You lie on the beach or you lie in your arms up and go like that. There is a scar there, and that is why some people say, "Well, I don't want that scar there." I'll be like, "Fine, okay. Well, there are other ways you can do it without putting that scar there." So next, number two, infraareolar, the one you're talking about, below the nipple, U-shaped areolar incision. That heals brilliantly. Because it's healed on the interface between the brown of the areola and the sort of paler skin of the breast, it blends in really well and can be really, really hard to see. I use it all the time for gynecomastia, for men breast tissue removal. I don't really use it for in breast augmentation personally. Again, they tend to use it more in America. I don't know why the countries, I don't know if it's relevant, the countries that use it, it's just that they do. The reason I don't like it is because, first of all, you have to cut through breast tissue in order to get to that plane underneath the breast. So it's a bit more traumatic because you're cutting through breast tissue. You are cutting the U below the nipple, so there's more risk of alteration of sensation of the nipple. And whilst it is a fantastic scar that fades beautifully, if it doesn't, and if you do get any problems with the scar's on the front. So as I say, it usually fades fine, but if it doesn't fade fine, you have any problems with the scar, it's right on the front of the breast, it's on your nipple. Whereas the one inframammary is sort of underneath your breast. Yeah, it's quite hard to see. So it's I would suggest that it's if there's a problem with the scar, it's a better place, and it does tend to settle well. The other place you can put the scar is the armpit. And again, there are people out there, again, on the continent, usually in Europe, people use the armpit incision. So again, I can't say it's a bad thing because lots of people use it, so they wouldn't use it, if it was a bad thing. And they get good results with it. And that's fine. And the reason I don't personally use the armpit is it is quite far from the armpit to get here. to get to the cleavage area. And it's really important for me. It's really important to get a nice cleavage. That's really the point of the operation. And also, there's some quite big blood vessels here, so I worry about any bleeding in those blood vessels. It's hard. It will be hard to control from the armpit. That's just me. You know, people who use the armpit one will say to you, "Oh no, that's fine. I can do it, and look at these great results I've got." And the beauty of the armpit one is there's no scar on the breast, so I can totally understand why it's a favored one. The problem is the scar is in the armpit, which is not a great place for a scar. It's a bit hot and sweaty. There's a risk of it not healing up very well, but you could argue it doesn't matter so much because it's hidden in the armpit. So that's where I am. I mainly use the inframammary scar for those reasons, but there are surgeons, and I'll say is go for a surgeon who is good and has got experience in using the incision you want. Because I've had people come to me and want the transaxillary, want the armpit one, and I'd be like, well, that's not me, you know, going for someone who's not saying it's bad, but if I did it, I probably wouldn't do it very well because I've not done it very often. And so I've done loads of the ones with that one. So I'm much more familiar with it. So if you find a surgeon who's good at it, by all means. I know a couple of guys, but they're overseas who do it. But you know, if you find someone who's got good experience with it, then go with them, because as I say, there's nothing bad about it. It's just different strokes for different folks. Roxana has done something. Is that clapping? Thank you. Clap yourself back or clap back at you. Keisha says, good evening. I have an appointment soon at your clinic and I can't wait either. Keisha, when you do a tummy tuck, do you repair the tummy muscle? Very good. So good question. I mean, very good. Very, very good. Keisha, yes, you do what is necessary, Keisha. The reason people need a tummy tuck is usually weight loss or children. These things have stretched the skin of the tummy, and the stretching force then goes, and you're left with excess skin. Now, when it's stretched the tummy, often the rectus muscles, your six pack, two muscles that go, I would demonstrate on myself, you know, two muscles go straight down, yeah, these two muscles, they often have lines going that way, but that's just lines on the muscles. The muscles are actually going straight down. Sometimes when you've had children or put on weight, those muscles split apart. So we do call it a repair of the muscles, but we're sort of not repairing them. We're just bringing them closer together. It's called divarification of the rectus muscles. Technical term there, just to impress you, my technical wizardry. So sometimes those rectus muscles, often I would say those rectus muscles are apart. You can tell yourself if you put your hand there, put your hand above the belly button in the midline, and lift your head up lie flat on your back, and lift your head up off the bed, or do a straight leg raise. Keep both legs straight and lift them both up off the bed. Just try and tense the muscle and see if there's a gap between the rectus muscles. Now, obviously, when we do the surgery of a tummy tuck, we can see that exactly. We can see the rectus muscles and see if there's a gap. There's supposed to be a little gap, but it's only supposed to be little. So if it's a bit wide, we will bring them back together, and that is what we call a repair of the muscles. We're not really repairing them; we just bring them closer together. And that is pretty. It's usually the case, not 100% of the time, but it's usually the case. But the other thing is, it does make it a little bit uncomfortable. So sometimes when you have the surgery, you get discomfort going up to your breastbone, as if it's sternum here. Up here, because the repair goes all the way up there in the midline, so that can make it a little bit uncomfortable. To cough, you know, every time you cough and things like that, you're pulling on those muscles, so it can make it a bit more comfortable. But you often do need to repair those muscles as part of a tummy tuck. You don't have to pay extra. You don't particularly have to ask for anything. Well, you can ask for it or talk about it, but you don't have to ask for it. It's just a routine part of the tummy tuck. We would look at those muscles and assess them and bring them back close together if required. Roxana, give me a wave to say hello, so you know I'm here and listening. That'd be live Q&A. That's a wave. I would. Well, look, Roxana, you know what I'm going to do? I'm going to look for a wave right back at you. Where's the wave emoji then? I don't know if I've got one. Well, that was, yeah, I'm not familiar with the wave emoji. Well, I think I am, but it looks different to your. Can I just type in wave? Anyway, thanks for Roxana. I tell you what, Roxana, you know what? I am on. That's not it, is it? No, that's not the wave emoji. I am on. Right. Oh, I think that's my. I think that will be my way. Keisha, thank you for coming to the clinic, and we can't wait to see you. And how do I get that off? And looking forward to welcoming you to the to the clinic. So, oh, actually, that is the same as your one, isn't it? That's your one. Yeah. Way straight back at you. That was worth it. Last question, guys. I'm on the last question here. Oh, hello. Got to say, if you've got any questions, get them in because I am on my last question here. So, let's have Keisha. You must be thinking something else about tummy tuck. Come on, let's have some other questions. Roxana, get yourself a question out there. Jade, you've had 2 questions tonight. So you got the gold star at the moment, Jade. 2 from different areas. Where's a breast implant, scar, and minimal BMI for bariatric surgery? Nice. So, actually, this is a question we've had on the Facebook. What are your thoughts on having a mastopexy and implants done in the same operation? Yeah, that is a good question. That is an informed person asking that question. They've obviously been around. They know what they're doing. So I have got thoughts about this, and it is a controversial is the wrong word. So I'm not going to use it. I'll use a different word. It is a area of discussion amongst plastic surgeons. There is a word. So it is an area that we do talk about at meetings, and people write papers on it. What should you do? And some surgeons will do it in one operation, and some people won't do it in one operation. The reason being that mastopexy and implants is a lot to do to the breast. It is one of the bigger operations you can do to a breast, and what the problems with it are when you do a mastopexy, you're making the skin as tight as you can. That's the whole point of a mastopexy. You want to make that skin tight and taut, and you want to remove that excess skin and make the skin tight and the breast tight. And when you put in implants, you're making the skin tight again. You're tightening the skin a double time. So you're making this, you're doing the skin really tight with a mastopexy, and then you're putting an implant in and making it tight, even tighter, tighter. Cornish coming out there. Brought up in Cornwall, as I'm sure you can tell. The problem is when you do a mastopexy, because you've got sort of T junctions of scars, and because it's tight, it's always a balance. To be honest with you, it's a balance with any plastic surgery or any sort of cosmetic surgery. A lot of the stuff we're doing is we're making skin tight, and because we're making skin tight, there's a risk that the skin can open up. If you make it too tight, it's going to open up. If you don't make it tight enough, it's going to still be saggy. So you've got to get the balance right. So the tightness is makes it prone to wound breakdown. And if you've just had a mastopexy, the wound breakdown is bad, but it's not a massive problem. It's it's just unfortunate. But if you put an implant in and you get the wound breakdown, then if you get an infection and the infection gets to the implant, you have to remove the implant. So it can be a bit of a nightmare. And for that reason, there's some very good plastic surgeons, well-respected senior plastic surgeons who do not do a mastopexy with implants. So that is why this question is being asked, because there's many people who won't do it, and they've got good reason to, and they would not be criticized for not doing it. There is many people who would agree with them not to do it. I do it in one operation, and I do offer it in one operation. But I always say to people, it's a big operation. It's got a high risk of complications. You're increasing your risk of complications by doing it all in one operation. The reason I do it in one operation, because if someone really is unhappy with the shape and the size of their breast, they want the shape, they want the breast lifted, and they want them bigger, then it's quite a big deal to say to them, look, you're going to have one operation, then you have to wait 3 to 6 months for the second operation, 2 lots of off work, 2 lots of paying, 2 lots of recovery. It's quite a big deal to say that to a patient. So if you're really sure you want it, then I do it in one operation. But if you're not sure, and if you've got one problem as an overriding problem, so if you come and say, you know what, my breasts are really saggy, and you know what, while I'm at it, I'd quite like to be a little bit bigger, I'd be like, why don't you just have a mastopexy and see if you're happy without having them a bit bigger? Just have the mastopexy, because if you want them a bit bigger, you can always later on have them a bit bigger. And as I say, a lot of people routinely do it in 2 operations. So if you're on the fence, similarly, if you think, you know what, they're not that saggy, and I'm not that, they are a bit saggy. If they're really saggy, you need a lift. But if they're just a bit saggy, I'd be like, well, and you want to mainly to be bigger, particularly if you want them to be a lot bigger, implants will to a degree will take up the slack skin. And so you might say, well, look, you know what? Implant, you could just have implants. The shape probably won't be great. The nipples will still, but you're seeing a bit low. You might probably want the nipples a bit higher, but you don't want all the risks and complications associated with mastopexy. Why don't you just have implants in the first instance, see how it looks, and then you can always have a lift later on. And as I say, many plastic surgeons will do it that way routinely. So for people who are borderline and thinking, actually, you know what, it's mainly the sagginess that worries me, or you know what, it's mainly the size that worries me, I'm not too bothered about the shape because I normally wear clothes and things like that. Then you can do the mastopexy or the implants. And I would encourage you to go down the one route if you're on borderline, and then you can always have the other one later on. So that's my take on it. I do it, but it's a big deal, and there's well respected. Just because if your surgeon said they won't do it doesn't mean they're a bad person. It just means that they feel that the risks are not worth it. So it's something to balance up. And good question, like that question. So Keisha said thank you, which is kind. Roxana said thank you, double thank you. Evenings from Tracy. Tracy, pick up yourself. How you doing? You may not be able to show us this week, but can you show a silicone implant and a Be-Light implant side by side? I can't show you this week, Tracy, because they're at the clinic. I was going to do it at the clinic. You know what? I'd been on time if I'd done it at the clinic. But don't you remember last time I did it at the clinic? The Wi-Fi was shocking. It was all blurry all over the place. So I came home. But Tracy, can I roll that over? I've got to remember now. Be-Light. And what, silicone implant? Yeah, there's not that much difference, to be honest, Tracy, but I will do it. The main thing about Be-Lights are they're white. They've tried to say if it's not white, it's not light. I think that's their strap. I don't know if it's a strap line, but the problem is polyurethane implants are a bit sort of white. They're sort of yellowy whites. They look a bit similar to polyurethane implants. But anyway, I will do that. That's good. Get a bit of interaction there, Tracy. You like it? Keisha, look at this. It's going crazy now. What is the best implants? You know what, Keisha? If I'd had time today, it's funny you should say that because I was going to do a video. Where is it? I made a little plan for a video that I was going to do today with exactly that. That was going to be the title: the best implant, the best breast implant. And basically, I don't want to spoil it. Well, no one's watching this anyway, so I'll say it. The best implant. I'll tell you the best implant. We can highlight this as being the thing about this Q&A. I describe the best implant. The best implant is really I haven't really thought this. I haven't really thought through how I'm going to do the video. So this is a good trial run. But basically, the point is there is no best implant. And when people talk about the best implant, they're talking about a make of implant. And I was going to draw a little sort of graph, not a graph, a table. And basically, you've got to think about the coating and the contents. So when you talk about the make, it's the coating and the contents. So all implants have got silicone. So the coating, or the shell of the implant, all implants are silicone implants, a silicone shell. So even saline implants have got a silicone shell. So people say, I don't want silicone in me, I want saline implants. You think, fair enough, but actually the shell is still silicone. But anyway, so the shell is silicone, and the shell is either smooth or textured or polyurethane coated. And then you've got, so that's one line. And then the other line, you've got the contents. So the contents implants are either saline or silicone. Silicone for implants, medical grade silicone is only made in one factory in the world. There's only one factory in the world that makes silicone gel for breast implants. It's in Texas. And so all implants, no matter what make they are, have got the same gel. There is a slightly different gel in Be-Light implants in that it is still silicone gel, medical silicone gel, but it's got these little microspheres attached to it, so make it a bit lighter. So silicone implants are a bit Be-Light implants have got a slightly different gel, but basically you've got saline or silicone gel. Now, if you want a polyurethane implant, or if you want a Be-Light implant, there's only one manufacturer that makes it. That's Polytech. So you have to have, so that's easy. But if you want a silicone or a saline implant, and if you want a smooth or texture, you can't have a saline implant that's textured, but if you want a smooth or textured implant, then there are different makes. as I say, I'm going to work this out when I do the proper video. I'm going to be a bit more clear about it. But there are different makes. I think it might be better if I drew out the graph. Maybe I should scrap the table. But anyway, there are different makes that make silicone textured and smooth implants. Allergan, you might have heard, like earlier, there's a someone who's Allergan, who's talking about Allergan implants earlier. They've been taken off the market. So now we've got Polytech makes silicone implants, Nagor, Mentor, Sebin. There's several makes that make polyurethane that make silicone implants. There's a few makes, and when someone says to you, well, "This is the best one," I don't think there is a best one. If there was a best one, we'd all use it. The analogy I was going to use, I'm going to run this by you now, this analogy, see how it flies, is like a car. It's like saying, what's the best car? A Mercedes or BMW, you know, or Lexus, or what's the best? The reason that for you want to get the best result, you're going to get the best result based on the shape of the implant. It's like the car. There's loads of different BMWs. Like, you know, one BMW 1 Series versus a Mercedes S-Class or something. They're totally different. It's the shape that's important. What do you think of that? So it's not so much the make. You have to get a good make, but it's the shape that's really important, not so much the make. Is that running that analogy? Do you like that? So it's the shape that's really important with the implant, not the make. You won't be able to tell if you've got a mentor implant, or if you saw a patient who's got a mentor implant or have got a Nagor implant who's got a Polytech implant. You can't tell by looking what make of implant they've got. So people worry a lot about the make, but for me the make's not important as long as it's one of these big companies. If it's one of the big companies, then I wouldn't be. I don't really have much of a view. You'll find the people who've got a view about it are the people often who can only use one make of implant, and they start telling you they're the best. But that's because that's the only one they make, because their company's got to deal with the manufacturers. We haven't got to deal with anyone. We can use any implants we want. Now, I say that we are limited. The hospital order the implants, so the hospital have got implants that they can order. So some implants they can't order. Someone asked for some implants the other day. I can't remember what they were now, but the hospital couldn't order them. So I'm like, okay, we can't use them, but they can use Sebin, they can use Mentor, they can use Nagor, they can use Polytech. So these are big companies. It's usually the smaller companies they can't use. So the big ones they can use. So they're slightly different with the warranty, slightly different with the way the texturing is applied. But as long as you use one of the premium range implants, and I say that because Allergan used to have a budget range called CUI, but you know we only use the sort of premium ones with a lifetime warranty. As long as you're using one of the main manufacturers, it is the important thing. The best implant is the shape, and the shape means whether it's teardrop or round, and the profile, how much it sticks out, and the width of the implant compared to your frame. So that's what's really important with implants. And people get really hung up on makes. Well, they don't actually, but some people do get hung up on makes. But I wouldn't get that hung up on makes. Oh, I've heard that Mentor are the best. Oh, I've heard that A&A are the best. You know, they're all good. But if you do think Mentor's the best, whatever, that's fine. You can have Mentor or Nagor or whatever. Personally, I tend to use Nagor simply because I know that, and people say, why, you know, why don't you use it? I use Nagor because I've been using them for years. I used them when I was in the NHS. I know the book, I know the range, I'm very familiar with it. If someone wants a Mentor implant, I'll be like, no problem at all. You can have a Mentor implant, but I have to get the book out and I have to just look at the dimensions to see, you know, I don't sort of know it off by heart. I just have to look. I don't know the range as well. That's simple as that. I think they're a good implant. I think they're a good warranty, good company, but then so a Mentor, you know. So yeah. We've got some questions coming in now, thick and fast. Roxana's straight in here. Thigh lift with lipo, is it a difficult operation to perform? Is it higher risk than a TT? Have been quoted more than TT. Is that about right? Oh, God, I don't know about prices. I wouldn't be surprised, Roxana. Two things about the thigh lift. Number one is that it is less common than a tummy tuck. It's less, we do them less than tummy tucks. And the problem with the thigh lift is there's different types of thigh lift. There's one where you get a scar up in your groin, and there's one with a bigger scar down your leg. for me, I think the best lift is going to come with a big scar down your leg, but that is quite a big operation. Similar to a tummy tuck. You could argue it's more than a tummy tuck because you've got more stitching, because obviously you've got 2 legs to do, and the complication rate is higher because you're going up into the groin, risk of wound healing and what have you. And is it so? Oh, I don't know what I was thinking. It is a difficult operation to perform because we don't perform it as often. I think that's I've often said there's no such thing as a difficult operation. There's only operations you know how to do and operations you don't know how to do. I used to do microsurgery when I was in the NHS. I did these breast reconstructions. They routinely took 8 to 10 hours. If you did a bilateral one, it could take 10, 12 hours. Microscope, operating microscope, big operation, took ages. And you might think that's difficult, but if you've done a lot of them and you're doing them all the time, it's not difficult because it's just following steps, following stages and just doing stuff. So the difficult operations are the one that you're less familiar with. So I think from that point of view, Roxana, I would say yes. A Roxana is a tummy tuck, a thigh lift is a difficult operation because we don't do them as often. And it is a higher risk than a tummy tuck because you're going up into the groin, it's hot and sweaty in there. And I wouldn't be surprised if it is more than a tummy tuck. Yeah. Is that helpful? Roxana, can liposuction be performed 5 months after a tummy tuck? I'm assuming you mean liposuction in the same area as a tummy tuck, do you mean? Now, that question saying, can it be done? Yes, it can be done. Now, I feel that might be a leading question, Roxana, because is that what are you saying in terms of a revision after a tummy tuck? Because if you're thinking of a revision after a tummy tuck, if you've got a bit of a bulge or something there, what I would say is, look, just see if it's going to settle. 5 months is relatively soon. 3 months is the minimum. Ideally 6 months, to be honest with you, really 12 months to let things really properly settle. So if you're talking about having a revision, if you think there's a bulge still somewhere, I would say it's not unreasonable, unless it's obvious bulge, to wait a bit longer. 6 to 12 months really before thinking about revision, because there might be still some swelling there and it might settle. I know you probably think 5 months is a long time, but there might be some residual swelling. If you're saying, look, I had a tummy tuck and I want liposuction somewhere else in my body, I'm like, oh yeah, fine, you can have liposuction 5 months after, no problem at all. Helen, can liposuction be performed 5 months after a tummy tuck? Hold on a minute. Wait a minute. That's the right multitasking, I tell you. Dear, oh dear. Right, Helen. Sorry, Helen. I was misquoting you. How long would you leave skin necrosis after uplift/implants before going back to surgery for debridement? Oh, Helen. It's a bad question. Obviously, Helen, I've got no experience of this whatsoever. What are you talking about? This is a bad situation, Helen, and this is why people I don't know if this is you, but if you know why people don't do an uplift with implants, because this is a bad situation. So terms like necrosis and debridement are like, oh my god, that's a terrible term, Helen. We don't like using those terms in cosmetic surgery because you can't get away from it. These bad things can happen, but that is bad news. So I'll tell you my view on that, Helen. There's 2 types of necrosis, dry necrosis and wet necrosis. So dry necrosis means it's black, sort of like a scab, really. And for dry necrosis, I would leave it. I would just leave it as long as possible. Wet necrosis, if it's wet, oozing, smelly, potentially infected, that's a different thing. You've got to want to go wash it out, maybe clean it out. The problem is, Helen, when you have a necrosis and you go back to theatre to debride that necrosis, it's almost like the perfect crime wound debridement, because you can never take away too much, because you can only take away too little. If you take away too little and you leave some dead tissue behind, then there's bad news. So you can never sort of take away too much. But I mean, I would worry if you've got an implant in there. That is a worry. Is that implant okay? If it's only a little bit of necrosis, then maybe it is okay. But the worry is, because you want to take away all the dead tissue, you're going to go as far as the dead tissue and then a bit further. So you're going to take away a bit more tissue than you would if you'd left it to separate and heal on its own. So to be honest with you, unless it's like massive, I would you know, the longer you leave it, the better. I mean, this is a difficult question because it's something that really you need to work with your surgeon, because you don't want a patient getting really annoyed because they've had a dressings for a year, you know. So you might obviously want to go back and if things are healing but slow to heal, you might debride it, skin graft it, something like that. If it's a big area of necrosis, it's going to take ages. But the general principle, the longer you leave it, the better, especially if it's dry, if you're well, if there's no sign of infection, the longer you leave it, the better, because then you can leave it to separate, let the body let it separate, and then you'll be leaving more tissue behind than you would if you had gone in and debrided it, because you'd have debrided it back. And the worry, you start debriding it, if the implant gets exposed, then you'd have to remove the implant, so you'd have to be consented for that, I would have thought. If the implant's still in, of course, your implant might be moved already. But that's bad news, Helen. I'm sorry to hear that sort of question come up, because that means you've had a problem. But yeah, I hope all's well, Helen. I hope you're all right if that is a problem that you're having. Roxana's got a 2-stage question here. I like it. How long do, second stage, implants last before they should be replaced? Good question. A lot of people say 10 years, don't they? Now, all the implants that we use have got a lifetime guarantee. They're built to last forever. The problem with implants, the main problem with implants is capsular contracture, going hard there. And that can start to happen around 5 or 10 years. But it doesn't, you don't have to have it changed if that starts to happen. What happens is the implants, first of all, you start to feel it. Then you can start to see it as a capsule, as a scar tissue contracts, and it makes it into like a golf ball. And then it gets painful. That's the natural history of capsular contracture. And if that happens, you might want to have them changed. You don't have to have them changed. They say the person who first had the implants in, the first 7 implants ever, Billie Jean May, was it? In the 1960s, has still got them in. They're probably really hard, but you know, so you don't have to have them changed. But if they start to go hard, you might want to have them changed. So there's no sort of time on it. We keep an eye on you. We keep you on a yearly follow-up if you want. You don't have to keep on coming back, but just to see how you're getting on. But that's the main reason. The other reason you might want to have them changed is rupture, which can happen at any time. It usually needs a significant amount of trauma, like a road traffic accident or something like that. You can get a silent rupture where you don't even know it's ruptured. But often if that's held within the capsule, it sort of doesn't matter quite so much as long as the breast shape is held. But so they may not need to be changed unless they go hard. So that's the thing to say with someone who's got implants in, and say, look, if you've got implants in, I'd say to you, don't worry about it. If you get a problem, let me know and we'll see if anything needs to be done. If you're thinking of having implants put in, on the other hand, if you're the other side of it, you haven't had implants put in, I would say to you, you should plan to need another operation. You will probably need another operation at some point. So you should plan for that, you should budget for that, because a second operation, like I was saying earlier about the capsulectomy thing, it's a lot more expensive than the first operation when you do a capsulectomy. It's an expensive operation when you do a capsulectomy. You have to remove all that scar tissue. So that is a big deal. So, yeah, Tracy, you can remind me. Oh, yeah, of doing the Be-Light implant. Good. Yeah. Thank you. Sonia, can you have more than one breast lift? Good question. Yes, you can. If you do anything like that, so breast lift and breast reduction, same sort of thing, can you have another one? Then really what you would want as a surgeon, what the surgeon would want is the op note, the operation note of your first operation. So ideally you'd want to know who, well, not necessarily who, but where you had your first operation to sort of write to, well, ideally you go to the same surgeon. That would be the best because they know exactly what they've done. But failing that, if you know the details of the surgeon, we would write to the surgeon and say, can we have a copy of the op note? And they're usually pretty good. They've usually got records. And because what you do when you do a lift is you isolate the nipple. You don't take the nipple off and put it back on again. You isolate the nipple on a stalk of tissue and then move it up. So stalk could be from the top, then swung up, or from the bottom and then pulled up. So the stalk is attached somehow. So if you've had one in the past, you want to use the same stalk because that's where the blood supply and the nerve supply is, because the blood supply and nerve supply are more at risk of with a revision mastopexy, a revision if you're doing a second lift, because there's scar tissue around there. You've got more risks when you do it second time around, but you can do it second time around, but there are more risks associated with it, and you really like to know what the way it was done first time around. Jade's on fire tonight. What is the difference between liposuction and Vaser liposuction? Whoa, Vader. What do you love it? Vader liposuction. I'm going to invent a Vader liposuction machine. I think you mean Vaser, Vaser, Jade, but Vader's a better. I think Vader actually is a lot better because Vaser sounds like laser, but it's not laser. There is laser liposuction, but it's not called Vaser. It's called like smart lipo and things like that. But anyway, so basically, liposuction is sucking the fat out, sticking a tube in and sucking the fat out. There are some ways that you can assist the liposuction, and Vaser liposuction uses ultrasound energy to disrupt the fat before sucking it out. The good thing about that is that you can use smaller cannulas, smaller tubes, because the fat is sort of liquefied a bit before you get to suck it out. So you can use smaller tubes. You can often be awake when you have Vaser because it's sort of less dramatic. It's not quite such a big tube that uses to suck it out. And the other thing that they talk about when they do Vaser, I don't do Vaser, just full disclaimer. So I don't do Vaser. So really you need to talk to someone who does Vaser, is they say that because the ultrasound energy creates some heat, there might be some skin retraction when you do Vaser. So therefore, sort of areas like the tummy, I'm like, I wouldn't really do liposuction to those areas, but Vaser liposuction, people say that it does create a degree of skin retraction. So on paper, it is good. It is a bit, as a surgeon, it's a bit tedious. You need a machine and all that sort of stuff. So it's not something I've ever embraced personally, because I think the results, you can get similar results, to be honest with you. I'm not sure how much better the results are. But people do, I think they've done a good job of the marketing with Vaser, so people do ask for it. But yeah, so that's what Vaser is, and not necessarily a bad thing. Speak to someone who does it and get a proper opinion. Well, that wasn't a proper opinion, obviously. That was a proper opinion, but maybe not as proper as someone who does it. Louise, good evening. You may not be able to answer, but would having an abdominal hysterectomy after a tummy tuck have any negative impact on the muscle repair? Thank you. I can answer that, Louise. Yeah, I can answer that. No, it wouldn't. So the only thing I would worry about, so basically when you do the muscle repair of a tummy tuck, as I say, you're not really repairing the muscle, you are bringing the two rectus muscles closer together. When they do a hysterectomy, they cut the muscle this way. They cut the muscle they cut actually through the muscle to get into the abdomen. So they cut it in a different way. You're repairing that way. They're cutting it actually through it that way. So they're not affecting your rectus repair. The only negative impact I would say if you're having an abdominal hysterectomy after a tummy tuck is they might mess up the scar. They'll probably use the same scar, but we take a lot of care with stitching up our scars. So not that they don't, I'm sure they do, but so if you need a hysterectomy, I would say, why don't you have the hysterectomy first, and then I'll cut out that hysterectomy scar when I do my tummy tuck. But anyway, but yeah, no problem with the muscle repair because you're bringing the muscles together. They're actually cutting through the muscle at 90 degrees to where we've repaired it. No idea if I'm making that yet. So basically, we bring the muscles closer together this way. They cut the muscle that way. They cut and go through, but we. Yeah, is that clear? Vaser, Jade. Yeah, Vaser. Vaser. So, Sarah, is it worth having lipo after a tummy tuck? So, surgeons won't do both procedures at the same time? So, surgeons. What are these surgeons, Sarah? These surgeons don't know what they're doing. So, surgeons. I don't know why these surgeons won't do liposuction. I know. Actually, I do. I retract that statement, Sarah. I think I know what you're talking about. So liposuction with a tummy tuck is quite normal. I'm going to stand up again. Get myself moving. So liposuction with a tummy tuck is these bits here. That these you see this svelte. See my svelte figure. So these bits here where you do liposuction with a tummy tuck. This bit you don't do liposuction. How's my audio? This bit you don't do liposuction at the top of the tummy when you're doing a tummy tuck, or I don't anyway. I don't think many people do. I think, well, actually some people might, but we worry about doing that liposuction that way. But having said that, it often pulls down, and it often, if you have got a bit of fullness there, it often pulls down and is not too full once you've had a tummy tuck. But if it is a problem, you then may need to have liposuction later to the upper abdomen, because that's the skin flap that gets pulled down. So all the blood supply is in that skin flap. So you don't want to be sticking a liposuction sucker in, which might interrupt the blood supply and affect the wound healing. That's the reason for it. So yes, many surgeons, myself included, wouldn't do liposuction to the upper abdomen at the time of a tummy tuck. So I was disrespecting those E surgeons, but now I feel bad because I am one of them. If it's indeed tummy, upper abdomen, tummy lipo you're talking about. Keisha, straight in. It's Keisha. Whoa. Can you have a tummy tuck and breast implants at the same time? Yes, Keisha. What are you talking about? Mummy makeover, that is known as. MOMMY, mummy. Oh dear, American term. But yeah, a tummy procedure and a breast implant is normal. Is not normal, but it's perfectly reasonable to do it all in one go because people just want one recovery and just get it all over with. But it is a big op, I would say, Keisha. You have to, it's a lot to take on, but it's not uncommon to do them both together. Tracy, I love the analogy from breast implant to car. Minis are the best. Yeah, well, Mini's a bit different because Mini there's only one in the range. So I say, but if you said BMW and Mercedes, I think that's a good, because there's a whole range. So a BMW, you could have a small BMW versus a big Mercedes. It's totally different, Thank you. May have to do a bit of work on that analogy. Roxana, yes, after a tummy tuck. What was liposuction performed 5 months after a tummy tuck? Oh yeah. So you can have that, Roxana. Now I can get these in order. Helen, thanks for your helpful reply. You're so much more helpful than my lady surgeon was. Wish I'd have come to you. Oh, Helen. Oh, those lady surgeons, honestly. Oh, well, that's kind, Helen. And I hope your lady surgeon is looking after you now. That's kind words. Thank you. Sarah, is Vaser lipo most suitable for the chin area and on the older person over 40? Over 40? Older person? What are you talking about, Sarah? Over 40? Older person? That's not the older person, Sarah. Honestly, take that back. Retract that statement. Yeah, I think you can do Vaser on the chin. A bit of skin retraction. I don't know if it's most suitable for the chin, but I'm sure you can do Vaser on the chin. Yeah, I say I don't do Vaser. You can do Vaser anyway. You can do normal liposuction on the chin as well. But yeah, maybe a bit of skin retraction will be good. So it might be good on the chin. Yeah, I thought it would be. Yeah, 49 still. That's still 40s. That's all right. Young spring chicken. Louise, I've eased your mind so much. Louise, that is good to hear. So you're going to have yes, don't worry about your hysterectomy. It's going to be fine. Sarah, whew, that was a rush, guys. Oh, thought I was going to get off early then. So thank you. Is that it? Jade. Listen, Jade, couldn't have done it without you. You're one of the early birds getting in there. Thank you for that. Oh yeah, look at this. I'm not a very good salesman. I should have put these on earlier, shouldn't I? I've got a podcast. I don't know if you guys use podcasts. Do you use podcasts? Anyway, this is all we turn into a podcast on iTunes. Look at this. Who put this on? Watch my daily vlog. It's not really a daily vlog. I have got a vlog on YouTube. It's not daily. I wanted it to be daily, but it's all too much to have it daily. But we have got a vlog. I don't know. Please comment, share. What's going on here? What's going on? What's happened when I turn my back? Wouldn't want to end up with a turkey neck. Yeah, that is a point, Sarah. That is a point. Maybe Vaser would be less likely to give you a turkey neck. I don't know. Speak to a Vaser person, but yeah, we wouldn't want a turkey neck, not for sure. D. Late starter D. Do you offer abdomen lipo under local rather than general? My friend has complications from anesthetic. Yes. To be honest with D, it's amazing what you can do under local. Well, I say local and sedation. But yes, local and sedation you do. It can be a little bit uncomfortable because there's a bit of movement. So your friend, if it is your friend you're talking for, it is something they have to be sort of on board with. I wouldn't sort of want to force it on anyone. But I think, yes, you can do abdominal liposuction. And, well, as I say, I don't particularly like doing abdominal liposuction that much myself because of the skin problem. So maybe, again, Vaser is better. Vaser is much more likely to be under local than under general. God, I should get a Vaser machine. Got Vaser work coming out of my ears now. Got all these Vaser patients. But yeah, you can certainly do Vaser and normal liposuction under local and sedation. Roxana, love your reactions to some people's statements and questions. So funny. Oh, look at that. Wow, I'm trying, Roxana. Sarah's going to look on YouTube. What, my yes, look at my vlog. Follow me. No, don't follow me. Subscribe to me. 175 subscribers on YouTube. You heard it. 175, I think. 173 or something. Yeah, my children are very, very proud of me. Right. So thank you. Glad I got my podcast / YouTube. Sarah, I feel so much more comfortable now having booked Tummy Tuck for October. Good, Sarah. Good. I'm glad about that. Go for it. Go for it. And I'm going to check out. And I'm going to go and have a lie down. And thank you very much for all your lovely interaction as ever. And you know what? I'm going to be here same time, probably on time, same place, 7 o'clock, Facebook Live. Sarah, thank you. Thank you. So if you've got any questions, please interact, ask questions on it, and ask questions beforehand. I'll try and remember to have a B-light implant and a silicone implant, so I can show you the difference. And not this, I don't know if that's going to be that interesting because one's just a bit whiter than the other one. But anyway, let's big it up. Big it up for next week. If you want to know what a B-light implant versus a silicone implant looks like, tune in next week, and I will be there here to answer your questions. So good night and have a lovely dinner and a lovely evening, and thank you all for being here and being so pleasant. Thank you. Good night.